Hi, my name is Bronwen Lafferty and I'm one of the clinical strategy managers for ConvaTec. I am a registered nurse and was a tissue viability nurse specialist before working for ConvaTec, and prior to that, a district nurse. I'm here to talk to you about biofilms, what they are, why they are a problem in wounds, and how they can be managed. So firstly, what are they? We'll start with a scientific definition. Biofilms are complex microbial communities containing bacteria and fungi. The microorganisms synthesize and secrete a protective matrix that attaches the biofilm firmly to a living or non-living surface. To simplify that further, at the most basic level, a biofilm can be described as bacteria embedded in a thick, slimy barrier of sugars and proteins. Bacteria have been around on this planet longer than us as humans. They have the ability to adapt to ensure their survival, and by forming a biofilm strengthens this survival mechanism. Laboratory studies have shown that bacteria can form very quickly on a wound, simply in a matter of hours, and can become a fully mature biofilm in 2 to 4 days. Let's now consider whether we can see biofilm in a wound. And this is something that causes great debate. Often clinical staff will be aware of a slime or a sticky film across the surface. Patients may also notice this. But we have to remember that bacteria are invisible to the naked eye. Therefore, a lack of visible film is not an indicator that the wound is biofilm free. So why are biofilms a problem? Once bacteria have formed a biofilm, they are better protected from the body's own immune response, antibiotics and antiseptics. The sticky slime acts as a barrier. In an attempt to get rid of them, the immune system produces a chronic inflammatory response. This stimulates the number of white blood cells, and then in turn, these secrete high levels of enzymes that can damage newly forming tissue. By inducing an ineffective inflammatory response, the biofilm protects the microorganisms it contains and increases exudate production. This exudate then acts as a source of nutrition and further perpetuates the biofilm. So as you can see, wounds with a biofilm can then be stuck in a cycle of increased exudate and increased enzyme production. This causes problems for both the wound and the surrounding skin, which is at risk of damage. Wound healing can then delay or stall completely. So for the patient, this can affect their quality of life, as they will have a wound that may be very wet and potentially malodorous and involve frequent dressing changes. For healthcare professionals, workload is increased by long-term non-healing wounds and overall increased costs for healthcare providers. As we can't necessarily see biofilm in wounds, we need to look for other clinical signs and symptoms. Does the wound have loose surface material that can be cleaned away relatively easily, but does this reform quickly? Does the wound respond poorly to topical or systemic antibiotics and antiseptics that only contain an antimicrobial agent? Does the wound respond favourably to a multi-action approach to wound care, using techniques such as cleansing, debridement, refashioning of the wound edges, and dressing with a dressing containing anti-biofilm technology? If we answer yes to each of these questions, we can suspect biofilm with increased confidence. So how can we manage biofilms in wounds? We have identified that they are a problem in terms of wound healing, and it has been proposed that we should presume that all hard-to-heal wounds contain a biofilm. To help us understand how we can effectively manage biofilm, it's useful to look at biofilm we all manage on a daily basis: dental plaque. Dental plaque, or tooth biofilm, is the most widely accepted cause of periodontal diseases. We all know when we clean our teeth at night how fresh our mouth feels, with no residue on the teeth. But by the following morning, our mouth and teeth feel less fresh. Our teeth may even feel furry. This is biofilm reforming. So we only maintain healthy teeth and gums through regular and repetitive oral hygiene. It's not something we can just do once a week and hope for the best. It's this repetitive action that keeps the biofilm at bay. Other aspects of hygiene also have to be performed regularly, such as hand hygiene and showering. So it's important that what we do to manage biofilm in wounds also needs to be regular and repetitive. Considering we have already discussed that it should be presumed almost all hard-to-heal wounds contain a biofilm, managing it is key to wound progression. The concept of wound hygiene was first introduced in 2019 with the publication of an international consensus document in 2020, defining hard-to-heal wounds with an early anti-biofilm intervention strategy, wound hygiene. Wound hygiene consists of 4 steps that should be performed regularly and repetitively as part of a protocol of care. These steps are cleanse, debride, refashion and dress. This involves cleansing the wound, debriding the wound and refashioning the wound edges to make sure the wound bed is as clear as possible before dressing the wound with a suitable anti-biofilm dressing. Wound Hygiene Protocol of Care was launched in 2020, and since launch, ConvaTec have supported clinicians around the world to include these simple 4 steps into their standard of care to help progress the challenging wounds on their caseloads. A survey published in 2021 found that where wound hygiene had been implemented, 80.3% of respondents reported improved healing rates. More information can be found on woundhygiene.com, where you can download a copy of the original consensus document, clinical case studies, and the latest publication from the Journal of Wound Care on proactive wound healing with wound hygiene. Or fill out the contact form and a ConvaTec representative will be in touch with how we can support you. Thank you.